So, varying roles of the nose and mouth in breathing. So I want to talk about, we're going to review the anatomy and physiology of the nose. We're going to explain nasal function. And then we're going to discuss the relationship of mouth breathing to obstructive sleep apnea and snoring. And then we're going to do the functional consequences of mouth breathing. And then we're going to discuss the physiologic consequences, functional and the physiologic consequences of mouth breathing. Okay, human beings, we are designed to be nasal breathers. The impulse to nasal breathe is instinctive. The union of the foodway and the airway, we talked about this, has caused adaptive problems. The use of the mouth as an emergency airway outweighs, however, the dangers of choking and infection. We need to back up because when we get colds and respiratory infections of the nose, we need to be able to breathe. Okay, so we have a picture up here. It's a really interesting picture. So here's a picture. Again, this is a 3D VR rendition of the of a head. So who wants to venture to tell me what that is? Volunteer, quick. Huh? No. Okay, get surprised anyway, Gloria. But the point is, this is airway. So what we're looking at here is nose, turbinate bones, maybe some polyps up there, and then this is airway. And so in contrast to that picture here, same thing. What we're looking at is nasal airway. The tongue is in the roof of the mouth, so you're not seeing airway. This is nasal airway, oral airway, and when you're looking at here is the extension of the oral airway. And so what's suggested in this picture here is a low tongue position, and the low tongue position is suggestive of a mouth breather and not a nose breather. And so when you see a patient like this, and when we saw those other x-rays today too, the fact is that what we want to note is that are they nose breathing? And the best way to tell is that tongue fitting in the mouth nicely. If the tongue fits in the roof of the mouth, it belongs there. If the tongue doesn't fit, chances are we have a problem there. That oral airway may not work so good. That nasal airway may not work so good if they can't fit the tongue in it. Okay, so what's the role of the nose? The nasal lining, we have a nasal lining inside our nose. Pseudostratified epithelium. In the pseudostratified epithelium, we have serous, mucus, and seromucous glands. We have capacitance vessels, and we have submucosal layers, and we have arterioles, all in the lining of our nose. The arterial system determines blood flow. The venous system are the capacitance vessel that determines nasal capacity, nasal patency. So the more these capacitance vessels swell, the more clogged your nose gets. It's not the circulation from the arteries. It's not an over-swelling of the arteries. It's the capacitance vessels not going down from that determines nasal patency. So it's the venous system that doesn't function as well to determine the capacitance vessels and nasal patency. The capacitance vessels, it's constriction and relaxation that determine patency of the nasal airway. And they contain smooth muscle. And smooth muscle is regulated by the sympathetic nervous system. And they are the most dense in the inferior and middle turbinates of the nose. And so, again, you don't have this in the mouth. And so when you have mouth breathers, the carbon dioxide is being blown off. And so the point is, we need, right now, room air. Room air's got 21%, maybe this room's 20% oxygen. Well, the 20% oxygen, we only need 6% in our bodies, in our blood vessels. So we say blood saturation. Saturated blood is 6% with oxygen. So what's the saturation with carbon dioxide? 6%. How much carbon dioxide is in room air? 0.3%. So we have to keep the carbon dioxide in. And that's a good function of the nose. And as the nose as well does another thing Rick is telling me that's involved with nitric oxide, not nitrous, nitric oxide. But the point is that this is sympathetic. So when you have low carbon dioxide, you have, in smooth muscle, you have contraction. Okay, loss of sympathetic tone and cholinergic stimulation cause arterial dilation and active secretion of mucus. We have the nasal cycle we talked about, 80 to 20 switch in the nasal capacity from one side to the other. Every 2 to 4 hours it occurs in 60 to 70% of all healthy individuals. The narrowest part of the nasal airway system contributes the most to nasal resistance. And that is the nasal valve. The nasal valve is this area in here, the cartilaginous area in our lower nose. Constitutes what's called the nasal valve. So, airway resistance. 2/3 of the resistance in our airway is from nasal resistance, 1/3 is pharyngeal. Okay, this is huge. That's the majority of the resistance to airflow is going to happen in the nose. Let's pay attention to the nose. That's the point. Nasal patency is affected by exercise. Exercise decreases nasal airflow resistance. It increases sympathetic discharge. It constricts the capacitance vessels. The posture. Increase nasal resistance when you're supine. So again, you lie down, your nose clogs at night. The increased nasal resistance and dependent nasal passage in lateral recumbent position. That's even if you're on your side. Okay, so here's the situation. This is the nasal valve, this whole apparatus. There's the external valve, and then we have an internal valve. And so when you put a breathe right on the nose across here, you're dilating internal nasal valve. And that decreases resistance to airflow by expanding the nose. Okay. And so anatomically, if Frank Netter's drawn the picture, it looks like this. And the area in which the valve exists is this area in here. It's the anterior part of the nose. And basically in front of the inferior turbinate bone. Okay, two types of airflow we know. There's laminar airflow and there's turbulent airflow. Okay, and that's the diagrammatic picture of what happens. So the subject of laminar versus turbulent airflow in the nose. There is there is argument. There are people who would say that the turbinates make, like airplane wings, make less turbulent airflow, and that airflow through the nose is a perfect airfoil, and there's no turbulent airflow. On the other hand, there's people who say that as soon as you put turbinates in there and the airflow goes around them, you have turbulence. And so these things are studied, but the functions of the nasal airway passages are to transport air to and from the lungs. So the nasal airway is involved in optimal conditioning of inspired air. We want to heat the air, humidify the air, filter the air. It's also involved in olfaction. And then it's involved in recapture, heat and moisture on exhalation. So it's very interesting because we don't think of this all the time. Yeah. In the B movies, they do what to tell if the patient's dead. They take a mirror and put it under the nose and they see, okay. But the point is that when you breathe in air, so you have a bronchial protective reflex. In a cold day, you take a deep breath through your mouth, you get a pain in your chest. The lung reflex doesn't want cold, dry air. And so you get this limitation of airflow immediately. It's a reflex, and it's painful. Okay, and so what happens is when your nose takes the air in, and you have these nasal vibrissae and ugly nasal hairs that you don't like so much when they grow too long, if you're a male, then the thing is that if you just breathe it, if you just let it out humidified, then you wouldn't be needing to drink all the time. And so there is a recovery mechanism. As you inhale, the air is moistened, humidified, and warmed. As you exhale, it's dehumidified, and it keeps the humidity. This is an extremely complex mechanism. So you have a huge recovery and recapture of heat and moisture on exhalation. So the large vascular surface area lined with ciliated mucosa maximizes olfaction and conditioning, inhale and exhale, humidification and dehumidification. This is fantastic stuff. Laminar airflow is not conducive to air modification. Heat and mass transfer occurs slowly. And so the contact of airborne particles and pollutants with mucosa is minimal when you have laminar airflow. The filtration is impaired due to less surface area to pass over. Turbulent airflow brings about better warming, filtration, humidification, irregular airflow, differing velocities, but it increases the work of breathing. So when we have turbulent airflow, is increased by projection of inferior turbinates and downturned nostrils. So when you see a nose like this nose is more suited for turbulent airflow than this nose. So the nose that looks like this is called a LEPTORRHINE nose form, and the nose that looks like this is called a PLATYRHINE nose form. Okay? And so this is important to keep in mind because LEPTORRHINE noses are, remember this, tall and narrow, the downward and inferior direction of the nares. They maximize mucosal surface to volume. They facilitate heat and moisture exchange in cold, dry environments. The airflow must negotiate a 90-degree bend from the external nares to the horizontal chamber. It's got to go up and it's got to go across, and because of the shape of the nose. There's a well-developed nasal valve and greater projection of the nose, high nasal sill, and projecting turbinates enhance turbulent airflow. So you got bigger turbinate bones. Okay, then in a PLATYRHINE nose, it's short, it's broad, and it's flat. We have a lower surface area to volume ratio, less efficient heat recapture. The nares are more anteriorly directed. Don't pay attention to the spelling of directed, please. And we have poor or no development of the nasal valve. And so there's no or poorly developed nasal sill. We have little or small projection of the turbinates. And ecogeographically, these people are warm weather settlers. And so you could imagine. So when we have laminar airflow, there's less laminar airflow in a PLATYRHINE nose than a LEPTORRHINE nose for the reasons we just did. So when we see a nose like that, Joe, LEPTORRHINE or PLATYRHINE? Come on, pay attention. Okay, Whit, answer the question. Pardon? Lepto, good. Okay, you're our quiz here. Huh? All right, wait a minute. Yes? Thank you. Okay, I'm listening. Yeah? Lepto, okay. Huh? What? Lepto. Okay. Okay. Lepto, good. Laddie. Okay. Oh, look at this one. We have a before and an after. Okay. So which one do we like better? Oh, wait a minute. There's another before and an after. So today, the favorite of the beauty queen is Lepto. The platos seem to be on the outs. Here's a plato changed into a lepto. Look at that. But she is against the trend. Nope, exactly. She went from this one, plata, to lepto. So lepto is in. Okay. And so why show the befores and the afters on the same person? Because when they do that, the fact is they're changing the shape of their nose in here, and the airflow can't be the same in both noses. That's physics. That's just high school physics. I don't know that they thought of it as high school physics when they decided to have the nose done, but that's what it is. There's two 90-degree turns in airflow. It goes up, it goes across, and it goes back down. And so we have varying cross-sectional areas throughout the airway. We have varying obstructions in the airway and varying thickness in the mucosal walls. And so the net accomplishment of this is warming, humidification, and filtration. And people, again, summarizing, who are PLATYRHINE noses or in warm places, they don't have to have the kind of heating because they're in warm climates of the world. And the people who live in the cold climates, predominantly leptos. And so their noses work differently and they have different capabilities. But it's interesting. Okay, so laminar airflow can't occur in both the before and the after surgically altered noses. So chances are they went from PLATYRHINE to LEPTORRHINE. Maybe it's working better. But I don't know, somehow I don't think so. Airway modeling studies, even at low flow rates and in PLATYRHINE noses, did exhibit turbulent airflow, according to a study by Simon in 1999. So no matter how flat, no matter how wide the nostrils, no matter how the PLATYRHINE nose is, there's still turbulent airflow. So turbulent airflow is the rule. And the nasal valve is the narrowest portion of the anterior nasal pathway. The nasal valve at the cross-sectional area is roughly 30 to 40 square millimeters. But just after the nasal valve, there's an abrupt increase that you saw as it goes across, and in that increase, it increases to 130 square millimeters. So there's a possibility of turbulence there. And then it goes back down again. So we have, must be turbulence. Okay, so the larger the nasal passageway exhibits more turbulent airflow. The smaller nasal passageway are less conducive to turbulent flow. Okay, air exchange either does not occur or occurs slowly between the nasal passages and the sinuses. Remember, we were looking at sinuses, Richard, earlier, and when we look at the sinuses, we're saying, well, what are the consequences of that clogged sinus? Well, there's no airflow, so there should be little consequence to that clogged sinus and breathing. Maybe infection, and maybe the infection is going to cause pain and generate pus or whatever, but it's not going to be affected. What's in the sinus isn't going to be affected by the flow of air. There's no airflow across those sinuses. But when these people, if you ever look at these now, and you see these patients who've had nasal surgery, they take that pinpoint airway, ostium, over which air would ordinarily pass, and they enlarge that, and then the air does go in the turbinates when they've had these surgically altered noses. And so when you see these surgically altered airways, all rules are off. So there's other obstacles to laminar airflow create turbulence as well. And we saw this picture earlier, and there's plenty of things in there in the oral airway that can create turbulence. And so airflow turbulence from the turbinates, tonsils, and adenoids. And so what happens is you get the air coming here, circulating over here, a little more turbulence over here, a little more turbulence over the tonsils, and then it goes in, and it can't not be turbulent, but on the other hand, the good news is it's warm, humidified, and filtered. And then the other point is that as it goes out, it's dehumidified and the warmth isn't kept. So it's a very incredible mechanism we have. Bernoulli's principle says that if you decrease the size of the lumen, an increase in velocity of air resulting in a decrease in pressure. So when you have this increase in a decrease in lumen, then you have the suction effect. It sucks in the walls, and this is what we're talking about. There's two factors now that are happening to airflow, and one is that the tongue can collapse on the airway and make the lumen smaller. The other is that the negative pressure can suck it shut. So that's what we're going to say. And Poiseuille's law says that an airway with a diminutive lumen increases in radius size cause exponential changes in airflow. So that's why when we see these airway where I said, hey, you know, it didn't look like there was a big increase in volume, based on the physics, it could have been huge. It could have been exponential just by making it 20% wider, and you might not see that on an iCat. And so you get these changes, and sometimes little is excellent, and on the other hand, sometimes huge have no clinical significance, or little. And so you can't quite measure that. Okay, and then care to, that's Poiseuille's law. And together, Bernoulli and Poiseuille, which are different, say that if you increase the size of the airway, you reduce the turbulence and enhances airflow and prevents collapse. So increasing the size. The contribution of the nose is based on Bernoulli effect. Nasal airflow affects collapsibility of the oral airway. That's what we just said. And then abnormalities affecting nasal airflow, nasal valve collapse, septal deviation, adenoid hypertrophy, nasal polyps, neoplasm, turbinate hypertrophy, swollen nasal membranes, and foreign bodies in the nose. Conditions causing increased nasal resistance. So we have allergic rhinitis, where we have the swelling of the nasal tissue, capacitance vessels as a result of an inflammatory response to allergens. We have trauma can do it. We have medications that can do it. There are as many antihypertensives or vasodilatory. And then we have hypothyroid, which can do it. and we have other diseases, and then in particular granulomatous diseases. So the consequence of a patient having sarcoidosis or Wegener's granulomatosis are increased nasal resistance. So muscles attached to the hyoid bone can also affect oropharyngeal patency. These are reflexly controlled by chemical and pressure changes. Increased negative pressure in the upper airway enhances duration and amplitude of electromyographic activity in geniohyoid, thyrohyoid, and sternohyoid muscles. Okay, so we have two primary factors. We repeated this. We're not going to do it again. The sniff test. We talked about the sniff test. You take a breath in. Seal your lips. Take a breath as deep through your nose as deep and fast as you can. If it's we have nasal patency and the nares flare, that's typically a nose breather. If the nares constrict, that's nasally obstructed breathing. So when you have the nares constrict like you see there, which is quite dramatic, then this is a nasal incompetence, and when you see the nares flare like that, that's going to be a nasally competent breather. And so it's a very easy test. It's quite reliable. The ENTs look at it and rely on it, and it works. And then we saw a case this morning where we had nasal obstruction on one side, and you had that. And so you can look at this stuff. It's very important. And the narrow side, the obstructed side, is going to be the side of the crossbite if it's unilateral. Okay, paradox. The symptoms of nasal obstruction often correlate poorly with actual resistance to airflow, because when you take that breath, mouth breathing doesn't always signify severe nasal obstruction. And you get a kid, and this kid has tonsils that are big, and he's got adenoids that are big, and so then he's got to protectively teach himself to alter the tongue position. He's going to lower the tongue position. He's going to change the swallow. He's going to change the posture, and that kid's going to be mouth breathing. This kid could be large tonsils could happen 1.5, 2, 2.5, 3 years of age. Okay, the kid gets to be 8 years of age, 7 years of age. You know the story here. So finally somebody says, listen, these tonsils are obstructive. We need to get them out. So you find a pediatrician, they meet criteria, and they take out the tonsils. Then you read the literature, it says 80% cure rate of apnea if you take out the tonsil. Wait a minute, why isn't it 100% and so on and so forth? And how come it's only 80? And that's 80 after 6 months. Kids get better. You don't teach that kid to breathe properly. This kid doesn't know any other way to breathe. His brain at a lower brain level is still mouth breathing. He hasn't changed his posture. He hasn't changed anything. The airway is less obstructive, but if you don't teach that kid to breathe with myofunctional therapy or various other methods, then the thing is, they don't know. So these kids may not be nasally obstructed, but they're mouth breathing habitually. And so there are mouth breathers who are not necessarily nasally obstructed. You may be one. And so that was an interesting case, if I could discuss it. Do you mind? Because with Sam's case this morning, he came out with AHI of what, about 19 was it? 19. And so, but the breathing rate was 24. So we said normal is 12 to 16. So he's hyper-breathing. That's what we picked up from the Metabite study. But he was suggesting that when he went skiing and got cold, you had asthma, and you were breathing what he said was asthmatically. So he'd been to doctor after doctor, and they haven't figured it out. And I said, hey, you're hyper-breathing. You're hypocapnic. And so we tested him on the capnic trainer up there. If we get some time, I'll be happy to demonstrate it. If anybody wants to come up at a break, I'll show you. But sure enough, he was hypocapnic. So now the answer is you need breath training. You go take a yoga course, go take a breath training course, go see a pulmonologist if need be, but we know what it is. And the idea that he's breathing, the key here is look at the breath rate on the Metabite, and we had a clue that he was hyper-breathing. If you're mouth breathing, so we started to say earlier, you're not keeping the carbon dioxide. You're blowing off the carbon dioxide, and you need to conserve carbon dioxide because there's only 0.3%. And so we have methods of conserving carbon dioxide, one of which is close your mouth and nasal breathe because the nose is doing this kind of conditioning. The nose has whatever it is, the nitric oxide, whatever it takes to create the carbon dioxide. And because if it gets blown off too fast, the carbon dioxide doesn't stay. The way it works is like this. For example, let's visualize this as a hemoglobin cell. And so you have carbon dioxide and you have oxygen on hemoglobin cell. That's not necessarily that you need low carbon dioxide and high oxygen. They go together. And so when you have a situation like this with high oxygen, high carbon dioxide, then it's easier for the hemoglobin to release the oxygen. Okay? And so the lower the carbon dioxide, the more the hemoglobin binds the oxygen. So it's not, common sense says, we don't want our patients hypercapnic, high carbon dioxide. Yes, yes. So if you watch the Olympics and you see the marathon runners, they're breathing 4 to 6 times a minute. Their mouth is shut for the 10. They're not, and when you're watching the Chicago or the New York Marathon on TV, as soon as they see that mouth open, they go, okay, so-and-so's collapsing. He's falling apart here because he starts mouth breathing. They're nose breathing. They're 4 to 6 times they're conserving carbon dioxide. If they're conserving carbon dioxide, they're getting the oxygen, and the rate on the capnometer is 35 is normal, 40 and 40 up to 42 or 43 milligrams of water pressure is where the carbon dioxide in these athletes is. They have high carbon dioxide, slow breath rates. When you see the rapid breathing, it's a low carbon dioxide. They're hypocapnic. Hypocapnic, the low carbon dioxide is causing, again, spasm of smooth muscle. So that's why we see adults. I had a weird case where a woman came in, and she's 64 years old. She's doing her day. She had a face job and a nose job and a boob job, and she looked sensational. And I look on the sheet, and I'm embarrassed. She's wetting the bed. So, wait a minute, this is terrible. I don't even know how to address this issue with this woman. But I talked to her husband. Yeah, sure enough. What am I going to think? I think, let's test her. First thing I did, put her on the capno trainer. She's breathing. Her CO2 is 20 instead of 35. She's breathing 25 times a minute. Send her out for breathing exercises. So, you know, it's a hard sell. People don't understand. So she went to the Mayo Clinic instead, and then she went to, not the Cleveland Clinic, she went to Harvard. She went to Harvard to find the answer. I haven't seen her recently, but to me it's black and white. It's very easy. And you gotta, these things are dealable. And so we just, again, we say, like with this, yes, you should train a kid to breathe through the mouth, and myofunctional therapists do it. If you have a kid with, let's say, a dysphagia, so we're old enough, many of us have sent that kid to a myofunctional therapist. They teach the kid to swallow correctly, and the teeth grow in better and everybody's happy, but the kid changes the swallow. And so if you train the kid to swallow during the day, he swallows correctly at night. Well, same thing, if the kid is breathing correctly at night, he's going to breathe correctly during the day. You take the tonsils out, you could send the kid for myofunctional therapy. Easier way, and kids are trainable, you tape the mouth shut. Now, this is a really hard sell, because people are almost all, you're going to go, what, are you trying to kill me? What, did you talk to my wife? No, try it. But for an adult, it could take up to 60 days to retrain the mechanism at the lower brain level. So you could try that. Taping your mouth shut in kids, it works in about 2 weeks to a month. So it's easier in kids. It's easier to tape the mouth shut than to train them, but again, the capability is there, the nasal competence is there. But you have to work, I mean, you have to do something to get them to keep the mouth shut. And so I got a roll of tape there, I'm going to have to try it, you know, or you're welcome. But these are the kinds of things. And so what happens is when you do that, if you do that, all of a sudden you wake up in the morning and you go, oh, finally I feel rested. And so that's why I say this problem is more complex than apnea hypopnea index. It's so complicated that all of a sudden we're dealing in respiratory physiology. We're talking to patients about carbon dioxide. So when they say, but my apnea went from 33 to 3, how come I still feel like crap in the morning? Okay, now we've got to start looking at the study a little more carefully. This is not something that your average sleep physician is going to look at. But we got the instrumentation, we got the capability. And this capnic trainer, it's like it's nothing. It's a toy compared to the expense we spend on some of these other toys we have in the office. I'll show you things. And so this is the thing. So here's the point. Mouth breathing doesn't always signify severe nasal obstruction. So you had an excuse. I'm going to get shouted at for being behind schedule, but and a question too. Oh my God.
Could you go over that point number 1? Symptoms of nasal obstruction often correlate poorly with actual resistance to airflow. Because I'm not sure I'm getting it.
That's the second point. The symptoms of nasal obstruction, because the mouth breathing doesn't always signify severe nasal obstruction. That's the corollary. Cold, dry air is deleterious to respiratory health and function. Inhalation of cold, dry air causes reflex bronchoconstriction, decreases pulmonary function. That's a protective reflex because you don't want to destroy lung tissue. Lung tissue is fragile. You want to keep the lung tissue as healthy as you can. You want that air going to the lung warmed, humidified, and filtered. Okay, so the nose is clogged. You got to breathe through the mouth. What warms, humidifies, and filters the air? The throat and soft palate. The redder, battered uvula that you see is going to do that better than a non-inflamed palate. So when you put let's assume on the basis of that study this morning, whoever had a 46, let's assume there's a red palate there. You're going to put in an appliance tonight. The idea would be incredible, and I'd love to see it go from 46 to 2, 3, or 4. That would be fantastic, because I'm trying to tell you the Moses is great. But it's not really a reasonable expectation because we're not going to heal in one night the palatal redness and swelling that occurs in the throat and pharyngeal tissue. And so you got to think about all this. This stuff is complicated. It's not as easy as apnea-hypopnea index. That's the point. The functions of heating, filtering, and moisturizing fall entirely to the nose and mouth. The nose is perfectly designed, and the humidification has to be continuous. Ciliary epithelium it's a conveyor belt for humidification. Filtration is accomplished by the vibrissae of hairs of the anterior nares. Dust is deposited on the mucus blanket covering the vibrissae and the moist mucosa. Based on small surface charges existing on the nasal walls, fine matter is attracted to this vibrissae from a distance of 2 to 3 centimeters. That's incredible attraction. And anybody know what the attraction, what the material's called when you get this stuff? Yes? Boogers. That's the end result. And so we have the nasal cycle, and supposedly in the nasal cycle, the body is cleaning them up, so you don't have to pick them. The body takes care of these boogers very naturally. And this is really a neat mechanism, isn't it? I mean, we can laugh, but it is. It's incredible. Okay. Turbinates increase the turbulence, increase nasal airway resistance. And so stimulation of the pharyngeal receptors induces the central nervous system to initiate oral respiration. We part the lips, we flatten the tongue, we raise the soft palate, and we lower the mandible. That's how we go from nose breathing to mouth breathing. This changes the whole physiology and the head posture on the spinal column. During sleep, in normal subjects, the pharyngeal airway partially collapses and increases airway resistance. Tongue posture is a prime factor in determining pharyngeal patency in sleep. Where's the tongue? We want the tongue in the mouth. And okay, so at some point in the early annals of I'm sorry, I keep going in the dark for you. I'm watching him follow me all of a sudden. In the early annals we had at Rush University came up with the tongue retaining device. Anybody know what a tongue retaining device is, or have you ever seen these? Yeah. So what they did was it was like they would do an upper device, an upper retainer, let's say out of silicone, a lower retainer out of silicone. Anybody know what an orthodontic positioner is? Okay, so it was an orthodontic positioner, except they had a bubble in the front. And you put the tongue in the bubble, and then you create a suction with your lips against it, and the tongue will be held forward with a vacuum. So Dr. Cartwright at Rush did a lot of research, and she proved this works like a charm. It's really effective. The problem is they had poor compliance and nobody wore it. The reality is physiology and anatomy, the tongue doesn't belong in front of the lips. So you hold the tongue out there, after a couple hours, the tongue starts to hurt. And so Samuelson, the inventor, he came to my office and he says to me, he's got 3 or 4 of these on the nightstand. And when his tongue starts to hurt from one, he puts another size in. And so you needed 3 or 4 to make it through a night, and nobody made it through the night. They worked, the studies were incredible, but nobody wore them because it was painful. So, okay. Obstructive sleep apnea patients demonstrate greater oropharyngeal collapse, loss of tone in oropharyngeal muscle, and less inspiratory drive in tongue muscle. Protruding the tongue affects oropharyngeal dilation and decreases airway resistance. Retruding the tongue increases oral airway resistance. Why? You put the tongue back and you got a smaller airway back there. You bring it forward and the airway is bigger back there. Simple stuff. So that's the ultimate in bringing the tongue forward. Let the tongue retaining device. But you can't have it. You got limits. You don't want the tongue beyond the lips. And so, functional adaptations of mouth breathing. So we said the soft palate is raised to make a nasal seal with the posterior pharyngeal wall. The mandible drops to facilitate oral breathing. The tongue is lowered from contact with the palate. The tongue shape flattens, and we have greater interarch freeway space because you have to have the mouth open, so the freeway space increases. Then swallowing occurs with the teeth apart. The scallop border of the tongue develops. We've talked about all this earlier. This is just a quick review. Dental alveolar intrusion of lower posterior teeth. That's the step plane of occlusion. Increased buccal wall pressure against maxillary teeth. You got the tongue in the floor of the mouth, so you have an open airway. You have buccal wall pressure on the teeth, and so the teeth, the lips and the cheeks contract and shrink the width of the maxilla. You have a narrow maxilla, you have a narrow nose because you have increased nasal resistance with a narrow nose. This is all stuff that we knew that we have tremendous control over. Lowered tongue position reduces the cross-sectional area of the pharyngeal airway. The narrow palate results in narrow nasal passage and increased nasal resistance. And then the dysphagia of the anterior tongue thrust, because there's several ways the tongue can go, depending on the tongue finding its path of least resistance. The tongue can come forward and open the bite, or the open mouth can result in extrusion of posterior teeth. So this morning I showed you a bunch of cases where there was narrow arches and anterior open bites. That's what can happen. And a characteristic of chronic mouth breathers is the forward head posture. The hyoid musculature contracts, pulls the mandible distal and inferior to maintain the open mouth. The suboccipitals and SCMs extend the head. That's the bend here. And the mid-trapezius and rhomboids are flexed. The resultant findings in mouth breathers, we have a long face, but you can also have a short face. We showed that. You can have an anterior open bite, you can have a high palatal vault, you can have a steep mandibular plane angle, malocclusion, incompetent lip closure, inflamed anterior gingiva, open gaping mouth expression, and forward head posture. Okay, so we have this. There's the gaping open mouth. And so what happens is, this is a good case, because in this case here, they did nothing. And so then this kid grew into this case. Now what? Now, here's a case, and when they come in, this kid's got apnea. What are you going to do, increase the vertical some more to put an appliance in the mouth? So now you got a problem. And this problem is, you've created a surgical case by doing nothing. We can avoid this. You see this, look at the chapped lips, the open mouth. This is not what we're looking for. We have this capability. We see this, and we want to deal with it. Here's the long face. Look at the strain to keep those lips together. Look at the strain. Look at those narrow nostrils. Look at the allergic shiners. Look at the nose itself. Long face. Okay, interesting case here again. Identical twins. Identical. The DNA is identical. Look at the difference. One caught a cold the wrong day of the week, and look at the way he developed. The other one didn't. And this is what happens. The question becomes, is this an epigenetic change? Will this change pass on from generation to generation? This is a question. They have mice, and there's one study done at Duke University where they fed half the mice prenatal vitamins. And the mice they fed prenatal vitamins grew up healthy, and they had full coats of fur, and they were fatter and healthier. The other mice grew up skinny and runty and ugly hair. And then when they mated these mice a second generation, the pretty mice grew pretty babies, and the ugly mice grew ugly babies. They found that it passed generation to generation. And that's the basic definition of epigenetic change. The DNA was identical in the ugly and the beautiful mice, but what happened was they had phenotypic expression changes in the DNA. And so this is what happened. Is this a phenotypic expression? It sure is, because this is not the same kid. The one is a mouth breather and the one is a nose breather, and the one is better looking than the other. And so, again, we don't know until we see the kids. Is this an epigenetic change? It's entirely possible. Okay, so you see these pictures, and this is what we see. So the question is, can mouth breathing cause obstructive sleep apnea? And I think I'm going to summarize this. Obstructive sleep apnea is caused by collapse of the tongue and the oropharyngeal airway. It's not exclusive to mouth breathers. Not all mouth breathers snore. Mouth breathing is a strong risk factor for obstructive sleep apnea and snoring, but it's not the proximal cause. And again, this is what we're talking about, Lee, is proximal cause. Is that the direct cause? No, it has an important role in it. But so mouth breathing is not the prime cause. There's other things involved. So let's conclude. Mouth breathing is a functional adaptation that results in structural problems. The extent of the structural adaptation is affected by the demands of the respiratory system, genetic factors, and reflex training. Oropharyngeal constriction is beneficial in mouth breathers for exchange of gases by increasing resistance, heating and humidifying the inspired air. The bronchial protective reflex is not a defect in regulation or flexibility, but a Darwinian functional adaptation. So what are the physiologic consequences of mouth breathing? Well, Takahashi says we have maximum tongue pressure against the lingual surface of the mandibular incisors. It's greater during oral breathing than during nasal breathing in both the supine and the upright positions. With a head forward posture and lowered position of the hyoid bone, mouth breathing results. And then what's the importance? What's the importance of this respiration? The importance of respiration is we need to supply oxygen to all 300 trillion body cells. We can't make energy without the oxygen. So we need to remove the excess CO2, true, in the tissue. That's, again, we're dealing in hemoglobin. And we need to remove other waste material. Breathing sustains life. That's the big red message. So let's look at breathing again a little more closely here. So basically it's very simple. We have two types of breathing. We have the central controller. In the brain, we have involuntary. That's the pons and the medulla. Okay, everybody's breathing all day long. We don't think about it. We're just breathing, right? That's involuntary. But we can do it voluntarily as well. So in other words, you want to play the didgeridoo, or you want to play a wind instrument, all of a sudden you're controlling your breathing. And Rick told us that if you control the breathing with certain wind instruments, you actually strengthen muscles and you don't have apnea. Okay, this is important stuff. So we have the cerebral controller, but then we have sensors. The sensors, we have choroid plexus, the lungs themselves, the nose, and we have carotid bodies in our neck. And the carotid bodies and the lungs and the nose are sensors which tell the system to upload oxygen or affect breathing. And then we have effectors, the respiratory muscles. So when you're playing an instrument, your diaphragm, your intercostals, your abdominal muscles, your tongue, and your accessory neck muscles are affecting your breathing. And so we have this cycle here where we have sensors, effectors, and the central controller is the brain, and it's either voluntary or involuntary. So why is carbon dioxide important? It activates the medullary center, triggering the breathing mechanism. It protects smooth muscle from spasm. It facilitates transfer of oxygen to cells from hemoglobin. That's what we just said. And it's necessary to maintain the correct pH balance. Because here's the story. Healthy breathing requires production and retention of CO2. So our bodies have to operate between 7.35 and 7.45. This is a really exacting mechanism. That's not a lot of leeway pH below 6.8 or above 7.8 and cells die. And so the acid-base balance is regulated by breathing. We convert CO2 into bicarbonate or carbonic acid. So we can affect the acidity or the baseness, the alkalosis of our body, the alkaline condition, by regulating CO2. So CO2 is incredibly important. The CO2 responds a lot faster than the oxygen too. When you deal with these kids, and let's say Rick said that you need 1, and they're AHI of 1, and they're treating a kid. In an adult, you have to be over 10 before they're going to treat the kid. So the point here is that in a pediatric sleep center, the most important thing is not the pulse oximetry at all. It's the end-tidal CO2. So how is that kid handling the carbon dioxide? The carbon dioxide is much more responsive to change, and they got to keep on that change so they can keep that kid healthy. So they're doing end-tidal CO2 in a pediatric center. They're not doing it in an adult sleep center. So a buffer is a molecule that can reversibly bind hydrogen atoms. There's 3 buffer systems in the blood: the bicarbonate, the protein, and the phosphate system. The bicarbonate system is you can breathe it, and the protein system is the hemoglobin, and then there's the kidneys, which can regulate it by keeping and retaining the water and the acid-base balance in the kidneys. So it's a very precise mechanism, and it's under a lot of controls. And there's controls on the controls. A low CO2 is called alkalosis. Mouth breathing accelerates the breathing rate. Hyperventilation results in respiratory alkalosis. The blood becomes alkaline. If its pH can be elevated above 7.45. So what are the consequences? It's serious stuff, because your pH is off. And then the oxygen becomes bound to the hemoglobin. That's what I showed you with my beautiful bottle demonstration there. And then the smooth muscle goes into spasm if you have low CO2. Okay, and so elevated CO2, increased acidity, you become acidotic, and the acidosis is a slow breathing rate. If you see the patient with a slow breathing rate, it's respiratory acidosis. Acidosis with a rapid breathing rate is metabolic. So in your case, we saw rapid breathing, low carbon dioxide, which is respiratory alkalosis. Oh, so that's what it said, elevated CO2, okay. And so basically this is another picture of the same thing. The pH is below 7.35, you have acidosis. The acidosis, if you have slow breathing, it's respiratory acidosis. Rapid breathing, it's metabolic if the pH is below 7.35. pH above 7.45, and if you have rapid breathing, you have respiratory alkalosis, a la Sam. And then the slow breathing is metabolic alkalosis. So, okay. And the important thing is, because look at, we're talking about sleep and AHI, and all of a sudden we're going into basic high school chemistry again. Wait a second. Maybe biochemistry in college. This is basic stuff that's finally coming together. Maybe we understand this, maybe we can use this, and we do, because we have a capnic trainer, we have an end-tidal CO2 machine, and we're starting to look at this stuff. So I said this to you, 21% oxygen in room air, in outside air, human bodies require 6 to 6.5%. There's more oxygen in the atmosphere than human body requires. So there's no need to store oxygen in the body. But the carbon dioxide, that's a different story. The carbon dioxide is 0.03% CO2 in room air normally, so the body needs to obtain the CO2 because more CO2 is required than is present in the body. We acquire CO2 by breathing, and it's stored in the blood and lungs. So here's the question. If you drink Perrier, you're getting more carbon dioxide than if you're in regular water. So the idea that you're not hydrating yourself, no, but you may be helping yourself more. There's a prescription. Okay, so we have the BOHR effect. And the importance of the breathing rate. At 40 milligrams of mercury pressure, the diaphragm moves. And this occurs at 6.5% CO2 in the lungs. Humans are triggered from birth at 40, Below 35 is hypocapnia. Ideal breath rate, 6 to 10 breaths a minute. Rapid breathing is 14 to 18. This is a textbook. Okay, and then so what Rick said is 6 to 12, but again, this is awake, and these are ideals. But 12 to 16, you're okay. 14 to 18, they call it rapid breathing. But when you get up to 20, you're depleting CO2. Hypocapnia, respiratory alkalosis, poor binding of oxygen results, smooth muscle spasm, enuresis, the kids are peeing in bed, high blood pressure, snoring, hypoxia, reduced energy, and disturbed sleep from overbreathing. But this reduced energy, the reduced energy is the excessive daytime sleepiness. This is the kind of stuff we're concerned about because AHI is not the picture. And you're going to get rid of the AHI, and they're going to say, how come I still feel lousy? And now we're touching on the answers. This is good stuff. Mouth breathing bypasses the nose. It bypasses filtration, warming, and humidification, and we're not storing the carbon dioxide. The mouth can deliver 5 times as much air to the lungs, but the air is not conditioned, and it's dry. The bronchial reflexes shrinks the passage to reduce the quantity of irritating air. Breathing becomes rapid and shallow. Lung tissue produces mucus to protect itself, and the CO2 levels become lower. So what are the physiologic changes of hypocapnia? Hypoxia, hemoglobin changes. We have decreased release, smaller decreased release of oxygen. The release of nitric oxide also decreases. We have cerebral vasoconstriction, coronary constriction, cerebral glucose deficit, less blood to the brain. This manifests itself as cognitive deficits. You don't remember what you had for lunch. You don't remember where you parked the car. You don't remember where you left the car keys. Buffer depletion, bronchial constriction, neuronal irritability, GI tract constriction. This is where you get into this irritable bowel syndrome. How many of these people have that we're seeing? How about magnesium and calcium imbalance, plasma potassium deficit, plasma sodium deficiency, antioxidant depletion? That's antioxidant depletion. That's just, we're talking now increased cancer risk. Well, I'm talking your game, Lee. This is oral systemic health. And it's not even just the realm of dentistry. This is the realm of physiology. Platelet aggregation, muscle fatigue, muscle spasm. This is important stuff. This is right up our alley. I see a question? So, I'm not looking at you. I'm not looking at you. Am I talking to you? Yes, but did we check your carbon dioxide? We'll check it. Let's see what let's see what end-tidal CO2 is. We have that here. I'll be happy to do it. Next break, you're on. And we'll see. But again, there was stuff there that was surprising. Yes. I mean, again, nothing's easy about this. And certainly, I don't have all the answers at all. It's just that what I do is I push to come closer to this broader solution. I look farther for the answers. And so, yeah, nothing about your health history or exam was very satisfying. But, yeah, again, we win 27. But was 27, did you look at that's what it said on your, oh yeah, but wait, there's an exception here. The reason you took off the thing, but you didn't turn it off or something, they talked about that. Talk to Rick about that, but I'll be happy to check in. There was something about the way you did it. Use the microphone. I know that. Wait a minute. Talk into there. You can talk loud, but I still don't hear.
The breaths per minute, what should that be?
Rick says when you sleep, it should be 12 to 16.
Okay.
The textbook that I'm seeing says it should be lower, breaths per minute. But 12 to 16 when you sleep is what he said. Okay, same list. What are the symptoms related to hypocapnia? Decreased physical performance, phobia, migraines, hypertension, ADHD, asthma attacks, angina, heart attack, cardiac arrhythmia, chronic fatigue. You still with us, Sam? Or we should call the paramedics here. Increased blood clotting, panic attacks, hypoglycemia, epileptic seizures, sexual dysfunction, sleep disturbances, allergy, irritable bowel syndrome, repetitive strain injury, and pain. These are our sleep patients. This is important stuff. What are the psychological implications of overbreathing? They can be debilitating. Personality changes, executive dysfunction, decreased problem-solving skills, decreased cognitive skills, decreased concentration, decreased memory, behavioral disorders. These sound like children we see every day if you got them, and apprehension, fear, panic, and frustration. So how about all these patients that have panic disorder? How about all these patients that are on Depakote that we see? These are patients. We got to start looking more carefully at hypocapnia. So how do we treat overbreathing? So we use an oral appliance. The more room created in the mouth for the tongue, the less likely it is to collapse on the airway or restrict airflow to the lungs. We want to get that airflow to the lungs. Teach breathing behaviors that facilitate optimal respiratory behavior to regulate acid-base balance and physiology. There are respiratory therapists out there. So a lot of these patients, let's say there's a patient has a stroke. Okay, the patient's breathing mechanism isn't working. There are therapists that can teach people to breathe without aid. There are respiratory therapists who can teach patients who have stroke to breathe. If they can teach stroke patients to breathe, they can teach these patients to breathe. Do we know about this? No, not before this. Do we think we can use these people? Yes. Is that somebody we should start talking to? Yes. And so the thing is, I'm giving your message over again. That's all. I'm reinforcing what you said. You're right. Everybody listened to him this morning? He said it well, and it needed to be said by somebody else besides me. Okay, behavioral breathing education. The scientific demonstration to eliminate bias and misconception. Patients will say, I can't get enough oxygen when I breathe. I don't get any air when I try to nose breathe. If I tape my mouth shut at night, I will die of asphyxiation. These are the misconceptions that we have to overcome to deal with some of these problems. What we're saying, carbon dioxide's too low, that can't be. That can't be. I mean, the people instinctively think that high carbon dioxide is bad and low carbon dioxide is good. Carbon dioxide is low or high, then oxygen is low. They don't compete with each other. They work together on hemoglobin. Instructions must be consistent with the patient's belief system. You have to find something for that patient that's going to work. This is what Gloria was talking about. Instruction must demonstrate regulation and disappearance of physical and mental symptoms and biochemical improvement. And so we can test these things. We're getting more and more sophisticated as we get more and more aware. So we can, I mean, again, I may be the only one in the room now that's got hypocapnia equipment, end-tidal CO2 testers. It's just coming. This stuff, it's not even expensive. The end-tidal CO2 device, which I'll show you, comes with heart rate variability monitor. You put the ear clip on and you're measuring heart rate variability. And I go, this is more than I can handle right now. I haven't even used it. It's still got the original clip on it. But this is stuff. Are we going to look? I look at heart rate variability. I have no clue as to what it's saying. But these are the kinds of things I think we're going to have to start looking at more carefully. And I'm looking for a course in this, and I haven't found it. This is amazing. But this is where we got to go. And, again, Leah's already there in a different way, and we're changing. It's still about teeth. But we didn't know how important and how pivotal they were, and we didn't deal enough with this tissue surrounding the teeth. How did dentists treat it? Okay, we did that. That's what the Capno trainer looks like. It measures end-tidal CO2, and then you can do the training with the heart rate variability. It's biofeedback. You teach the patients to breathe using biofeedback. Here's what the thing looks like. The line at the top is 35. If you could get them breathing above the 35 threshold, they do very well. So this is what the screen looks like. This patient's ETCO2 for the time that it's being recorded here So it's 36.6. That's over the threshold. You can see it topping here. Breaths per minute, 12.8. Bingo, really nice. And every one of these is a bar. This represents where the CO2 was. So they started out, they were a little below it, but as they sat and relaxed a little, they went above it. And then this is saying here, these are breaths per minute. And so what we can see is that the breaths per minute went up here, but the breaths per minute is right down there. And so the next scene I think will show that, yes. So what happens is you can set the rate. There's a bouncing ball. Inhale, hold the inhale, exhale, hold the exhale. Inhale, hold it, exhale. Inhale, hold it. Inhale, hold it, exhale. And so you can set the amount of time you want for this. And so you could say, well, let's train them to breathe 8 times a minute. Why? Because at 8 times a minute, you might notice that you get the kind of change you're looking for. The slower the breathing, the more carbon dioxide is retained. So you teach them to keep the mouth shut, and you teach them to practice with the bouncing ball. And so this is inhale, hold it, exhale, hold the exhale. And so that's what's happening there, and you can set this anywhere you want. So what we've been doing in the office, for example, is we give them the whole DVD, CD, whatever it is that comes with the with the instrumentation. They don't have the end-tidal CO2. They don't have the cannula. But we give them the CD, and one of the things on the CD says something like carbon dioxide training. One of these says something, CO2 graph training. So you give them the CO2 graph training is this. Then you push the right button somewhere over here, and then you push the record button and so on. And the ball, they just go home, tape your mouth, and follow the bouncing ball. And then we have another problem. Sometimes people are neck and shoulder breathing. So when we did the exam, I remember your neck and shoulder muscles were not so tender, which suggests to me more diaphragmatic breathing. And so diaphragmatic breathing is belly breathing. And so if you tell the patient like this, grab your hands behind your back and pull, and stand up as straight as you can, and pull your shoulders back, and this forces the patient into a belly breathing position. Keep your mouth shut and just breathe like that. And if you have them on the Capno trainer, then eventually they're going to increase. They learn the feeling of belly breathing, and it takes the neck and shoulders out of the breathing equation, and they follow the bouncing ball. They come back in, and sometimes in a matter of 2 weeks, they're trained. They know how to do it. It seems so baby easy, and sometimes it is easy, and sometimes it's not. And then sometimes you have the key question, you don't smoke, do you? And they go, why, yes. Say, okay, fool, go home and get the hell out of here. I mean, I don't want to talk to you anymore, but that's the kind of thing, you got to ask the right question. You don't smoke, do you? Yeah, oh, okay. That's the reason your oxygen is low and your carbon dioxide is high. But in any case, it's just another tool we have, and it's very easy. This one here, yeah, CO2. There's graph training. That's the CO2 graph training one, and so we have that as a possibility. Okay. Here's what we go. Just like we said, 398 breaths. Right up here, it tells you what the total breaths is. And when you look at the printout, it's a little different printout. No, it's the same printout you use. And so it says total breaths 5906. So you go to the computer, or you go to the calculator, you go to your pencil and paper, and you divide this 5,000 by 398, and it comes up 14.8 breaths per minute. Is that hyperbreathing? No. Okay, done. That's how we did it. But again, in your case, Jan, it's a whole night of study. You can ask Rick, and he had a reason why that wasn't hyperbreathing. And maybe it is. Okay. So let's conclude this part. Treatment of sleep-disordered breathing is dependent on dentists having a broad education in basic sciences and training to apply that education to clinical experience. That's it.